So in this part of the video, I just really want to talk about stability exercises. Now, it stands to reason that if we have a stiff joint at one point, possibly above or below it, there's going to be an area of freedom, laxity, if not laxity, but freedom, give. And so what might happen is that as the joint is moving too much at that point, muscle tissue will go into spasm to protect that, to guard that. And that will then sort of have this knock-on effect of joints not moving and further guarding, further muscle tissue, spasm, trigger point formation, what have you. So it stands to reason that if we can see an area, and I spoke earlier in some of the assessments, where we see this kind of hinging, or we might feel that the joint is a little more free, got a bit more play in it when we're palpating, that there's a place to stabilize the area. Remember, mobilize the restriction, stabilize the give wherever it is. The thing with the stability, it's very, very hard to be specific. If we are unable to turn around and say, oh, at this particular level, I've got my fingers, I'm on L3, it's pretty difficult to turn around and say, well, I'm activating multifidus at this area. So some of the stability exercises may be quite general. And that's not a bad thing, because simply if we can mobilize the restriction, relieve the tension, get things moving, but at the same time providing a core stability, that can help us, and certainly as part of a home regime, empower the patient to continue in their progress and their journey towards having a pain-free life. And again, it feeds nicely into the biopsychosocial model. Basically, there are lots of exercises. One only has to go onto the internet to look at it, but some really nice basic exercises are bridging, whereby we get the patient to lay down, get them to lift up their pelvis, try and maintain a stable back. They can hold that, count to 20 or 30, maybe repeat that 5 or more times and relax. Another way they can do that is by bridging, and a little bit more advanced, get them to bridge and try and lift their leg up and stabilize it. Now here we've got a model who is, and relax, as the term goes in English, as fit as a butcher's dog. She is really, really strong. And most people would struggle with this. What you would need to watch out for is, if I can just get you to do that again, she has no problem bridging. And she brings her leg up, she still doesn't have much problem bridging. Most people will do that. So you will teach and try and train them to hold that, relax, and then with the other leg. And take the other leg and try and maintain this neutral, non-rotational part of the pelvis. And relax. Another technique is the plank. So this is the plank position. This is the purest plank position. It can be made harder by actually going up on the hands and knees, but most people, to maintain a sort of nice straight spine, can carry it out like this. In some cases, like myself, to avoid sort of any major injuries, I would need to do it on my hands and knees, and I may even need to just bring myself completely back and come back with your elbows and your arms as well. And even start in this position before I go into the plank. And even may try and activate transverse abdominis by just basically, rather than curving up at the thoracic spine, pull my stomach in, relax again, relax, relax. You're not going to move here, you're not going to move here. You're basically going to pull your stomach in as if you're going to stop yourself needing to go to the toilet, is how I sometimes find a very good description. And then I will hold that, and when I find that, or the patient finds that easier, then I will go into the plank position, which we did earlier on, where they're on their knees and on their feet. So if we go into the plank position again, and just drop down, and they will maintain that and try and hold that for 30 seconds or more if they can. The next technique we can do is if we go back up again into that position where you're on your hands and knees. Some people call this the bird dog. It has different names. It can be progressed. The idea is to maintain a neutral spine without any sort of twisting and turning of the pelvis in any way, either side flexing that way or rotating there, because if somebody has give at a particular structure, that's where it's going to occur. So for example, we would start off here and then to progress it a little bit, we get the patient to hold their arm up and again just bring their pelvis back, and sometimes they can get them to just rock backwards and forwards but maintaining their spine in this sort of straight position, not letting any sort of rotation or side flexion creep in at that point. Then we can get them to take their arm down and have a rest, and we could then load it a little bit more with the leg. So we get them to take their leg out behind them. Now that's a heavier weight. Again, it's going to cause the rotation at the pelvis, possibly some side flexion. Train them, teach them so that doesn't happen. And then relax. And now we're going to combine those with one arm, one leg, obviously at a diagonal, because if you take that arm up and that leg up, we're going to have one client on the floor. So they can hold this, and again, this is a lot harder to do. One tries to maintain a normal spine, a neutral spine, without too much rotation. It's getting pretty hard to do that for any amount of time, and relax. So these are very good stability exercises. They're very important. Remember, it's not contradictory to carry out stability exercises when you're mobilizing or treating lumbar spine. Although it's more common, or probably the more commonly approached elements of the restriction, the stability exercises give us an awful lot, so that we don't have to keep coming back and treating the restrictions or recurrent restrictions or recurrent problems in low back pain.